to the elevated troponin levels and they were asking for treatment, then just say to yourself, oh man, somebody's having a heart attack, oh man. Trigger your memory as to what we need to do. Notice it starts with oxygen. All right, that's the first drug we give everybody is oxygen. Then heparin, that's going to help minimize the possibility of further clots getting up into the coronary system because we don't want any more. Morphine will help reduce stress on the heart, calm the patient down, give pain relief. Aspirin will also work to keep blood clots from forming, as to keep the platelets from aggregating. And then nitroglycerin is a dilator that specifically will vasodilate the coronary arteries. And if we dilate the coronary arteries, you should be able to get some more blood to the heart. That's what we're after, trying to get blood to the heart. Other treatment that might be included, you see beta blockers are listed in your book there. Those can be helpful. Okay, so propranolol, calm down the heart, take some stress off the heart. Also drop down, you see ACE inhibitors are listed. ACE inhibitors are vasodilators, so they take pressure off the heart, and so on. And you can read through that. Okay, but the key is going to be, oh man, that's what you want to start with, and that'll take care of things there. The next one describes the STEMI, which is the ST elevation MI. Okay, so instead of the ST segment being depressed, it's now elevated, but it's still a heart attack either way. And so the same process, you're going to see chest pain, you're going to have shortness of breath. It mentions you'll have an S4 heart sound, so we know that's an abnormal heart sound. All right, and then the EKG gives it away. Classically, you'll see the ST segment elevated. Again, the biomarkers will be important. Troponin, again, is going to be the indicator. So if you see troponin levels are elevated, that indicates it is, in fact, an MI. But you'll be able to paint the picture pretty clearly as you read the information they give. That's going to be the key assessment for it. And then treatment, same song, second verse, so you don't have to learn anything new, and that's, oh man. So oxygen, heparin, morphine, aspirin, nitroglycerin, same thing. The only thing here is we may want to consider going to the cath lab. So if it looks like they are going to need more support than what we're giving them, then we want to get them to the cath lab right away, and we can then do a balloon reperfusion. We can get a catheter up into the coronary artery, and then inflate a balloon to dilate the coronary arteries and get the blood flow back to the heart. And it says we need to do that within 90 minutes. So they say from the door to the balloon in less than 90 minutes. So from the time they enter the emergency department to the time they get that balloon needs to be less than 90 minutes. So that's moving fairly quickly. And so you have to assess that. So if it is a STEMI, that's more serious. You start with the same therapy as you would before, but then they may do that for you and then say, what else would you want to do, or what do you want to do after that? And that's get them to the cath lab, and we may need to do that. So inserting a stent then while they're in the cath lab so they can open up the coronary arteries. That'll get blood back to the heart. That's great. And then as long as they're there, they can go ahead and put a stent in, and that'll hold it open, and that might be all they'll need. Okay. Now it also talks about 30 minutes from the door to the needle. This is if you're going to administer the drug like streptokinase or TPA. These are drugs that will actually go in and break up the clot. So if they feel that that's necessary, then you'll need to do that within 30 minutes. So you'll be doing that even faster than getting to the cath lab if you feel it's that severe. All right, so a little more aggressive then when you get to the STEMI heart attack. Now, the next section that we get into is neurological disorders. The main one that we want to look at is intracranial pressure management. If somebody's had head trauma or head surgery or any kind of problem that's causing intracranial pressures to rise, that can be very dangerous, and that's a critical care scenario here. So it starts out by talking about what causes increase in intracranial pressures and swelling of the brain. This is due from trauma, typically, or surgery. Hematomas that occur within the cranium will put pressure on the brain. Okay, so those are the things we're looking for. This can be assessed in different ways, but if you come down the page, number 3 talks about cerebral perfusion pressure. That's going to be important to monitor. So for whatever reason they're having intracranial pressure problems, we need to monitor that, and then we need to calculate this cerebral perfusion pressure, because that's going to determine whether you can get blood to your brain or not. So to calculate that, it's a simple formula. You take the mean arterial pressure. Remember, that was the systolic and diastolic, and we calculate a mean pressure. We doubled the diastolic, added the systolic, and divided by 3. Normally that's in the low 90s. So you take that number and then you subtract the intracranial pressure, because that's the gradient then that's pushing into the brain. And so as the intracranial pressure gets higher and higher, then you're losing more and more of that pressure gradient. And so it says the normal range 60 to 100, but we've got to maintain the perfusion pressure somewhere between 50 and 70 in order to get blood to the brain. If that drops to 20 to 40, that's critical, meaning you're not going to be getting adequate perfusion of the brain. All right, so we have an intracranial pressure monitor. We're monitoring the pressure up there. We can also monitor the pressure of the mean arterial, and then we can calculate the cerebral perfusion pressure. So it's a simple calculation. You should understand how to do it. If they ask you to do it, you should know what's normal. We always got to know normal. And then when do we draw the line? So if it's dropping below 50, then we've got a problem. We want to keep it above 50. Normal is above 60. Okay, but if you can keep it above 50, then that should be adequate. But if it drops below that, then we're starting to have serious problems. Now, the question then becomes, how do we reduce intracranial pressures if they're getting higher and higher and higher? And so if you move over to the next section, if you've got your book, go to number 7. And number 7 says therapy to reduce intracranial pressure. This is really what you're going to need to understand. And the first thing listed is to lower the jugular venous pressure. Okay, so patient positioning can help do that. It also mentions that turning the head or flexing the neck, or moving trach tube ties around, anything like that might cause an impeding of the venous drainage back to the heart. And so we need to minimize any increases in central venous pressure. So they specifically say we need to elevate the head of the bed, so look for that. They might have you do that to a 30-degree angle. And then don't try to have any coughing or retching or straining or even moving around. When it comes to intracranial pressures, the patient can be their own worst enemy. And so they're laying in bed, they're uncomfortable, they want to turn a little bit, they want to get off their backside, or they've got an itch, or they need to cough. Anything like that, which seems fairly innocent, can really spike the intracranial pressures. And so you want to minimize that. So if they're having problems with that and they're not, laying still and behaving themselves, you're going to have to intervene with medications to calm them down, sedate them. You may even have to paralyze them to keep them from hurting themselves. If they're on a ventilator, you want to keep PEEP levels to a minimum. Any kind of positive pressure applied to the chest is going to transfer to the brain as well, so that's a problem. Other therapy, it says to minimize cerebral oxygen requirements. So minimize stimulation, right? Keep them quiet. Don't let them have a fever, because that will increase metabolism. We don't need that. And then it talks about barbiturates. We mentioned that. So sedating the patient with phenobarbital, that can be helpful because that decreases the metabolism of the brain. So we're not demanding as much oxygen. Propofol, we've mentioned before, is a very popular drug. It's a good sedative. Other benzodiazepines can be used, such as Versed or Ativan. Those can be used to calm the patient down. All of that is just to calm things down, minimize the metabolism of the brain, so it's not trying to use as much oxygen as it normally would. All of that is protecting the brain from damage. When it comes to blood gases, we'll get to that here in a second, but when it comes to blood gases, we'd like to maintain good oxygenation, and if anything, over-ventilate a little bit. And so that can be helpful. And so we want to do things like that. Okay. Now, as we work through all this, it talks about other agents that we can use. Mannitol is a drug that should come to mind. You'll see that listed on the page 18. So mannitol is a good drug. It's an osmotic diuretic. So it goes up to the brain and it pulls fluid out of the brain, reduces the swelling, and that can be great. That's what we want to do. And then, as I mentioned, hyperventilation. Increasing ventilation, you can actually hyperventilate, and it temporarily decreases intracranial pressure, but it's not a long-term solution. But they may offer that, and you can do that right away. So adjusting the ventilator to decrease the CO2 to a range between 25 and 30. So normally we want the CO2 between 35 and 45, but now we want to drop it down to 25 to 30. That will temporarily drop the intracranial pressure, and that can be helpful while you get other therapies going. Get the mannitol started, and get the narcotics and the benzodiazepines so you can sedate the patient. But all those kinds of things can be helpful, and you may need that. Okay. All right. The next section we get into is seizure disorders. Seizure disorders, this is something you would observe in a patient, and it can be mixed up with other pathologies such as having a stroke or other things if they are an epileptic. But when you observe a seizure, okay, a lot of things can be causing that, but what's most important for you to understand here is if they are having a seizure and they're looking for a treatment, what drug would be the drug? And if you come down to treatment under number 6, letter A, you can highlight that. It talks about anti-seizure drugs, specifically Dilantin would be the drug. So the main treatment for a seizure is to determine what the